Great. Well, hello, everybody. Good afternoon for those of you in European time zone. My name is Peter Bannister. I'm a trustee of PIP-UK, the Poland Syndrome charity. And as a biomedical engineer, I'm as interested as I'm sure you all are in hearing what the clinical experts we've been lucky enough to bring together today have to say about ways of treating Poland syndrome. Before we start, I just wanted to say a few words about PIP-UK, the Poland Syndrome charity itself. So our vision is to be at the centre of expertise for Poland syndrome research, well-being, support and connection, with a mission to advocate for earlier, consistent diagnosis and treatment paths for the Poland syndrome community, building awareness for Poland syndrome and providing support for the community. And our main goals are centred around generating scientific activity, like today's session, connecting people across the Poland syndrome community and supporting their well-being. I think it's important to say that although we're actually called PIP-UK, we are an international organisation. And one of the initiatives we've led over the last few years has been to establish a global register of people who've experienced Poland syndrome and Poland-like syndromes during their life, which we'll talk about a little bit later. A key part, as I said, of our role is to raise awareness around the condition and support families and patients with Poland syndrome. And we were delighted at the end of April, so just a week ago, or a month ago rather, to have celebrated the first International Poland Syndrome Festival over a couple of days, which included, amongst other things, support from celebrities such as Matt Goss, who himself is someone who's got Poland syndrome. So without further ado, I'd like to take the opportunity to introduce our speakers today, our panelists. I'm delighted to welcome back from our very successful first scientific webinar, Andrea Jester, and also to bring into today's session, Giampiero Soccorso. And we may be joined a little bit later in the session today by Grainne Bourke, depending on her clinical commitments. But without further ado, I'd like to allow our panelists to in turn introduce themselves. And then we've got a fairly packed agenda, given the interest level in this topic, and move through some of the key considerations in terms of today's topic, which is around the role of chest reconstructive surgery for paediatric Poland syndrome patients. So, Andrea, if I could first turn to you and ask if you could introduce yourself to the people joining us on today's session.
Thank you very much for the invitation, Peter. My name is Andrea Jester. I'm a pediatric hand and plastic surgeon. And we have the honor to run Poland's multidisciplinary clinic, where 3 consultants, specialists look after patients, a hand surgeon, a plastic surgeon with an interest in breast reconstruction and chest reconstruction, and a chest surgeon looking after the chest.
Brilliant, thank you, and great to have you here today. Giampiero, can I ask you to introduce yourself, please?
Yes, again, thank you for inviting me. I'm Giampiero Soccorso. I'm a pediatric surgeon here at Birmingham Children's Hospital with a special interest in thoracic surgery, including chest wall deformities and reconstructions.
Brilliant. And again, wonderful to have you here, and thank you for your time today, Giampiero, and Andrea, of course. And very interested to be learning from your perspectives as both clearly practicing, but also very research-versed clinicians. Before we move to some of the questions, I just wanted to let everyone know who's on today's session that this recording will be available on demand to watch again via the same link that was shared with you to join today's session. And I think we may have, is that Grainne?
Oh, sorry, my name's wrong. Yes, hello.
Hello.
I'm Andrea Jester too. Sorry, I need to change that.
My twin.
Lovely, Grainne. We just done introductions, so could I ask you to introduce yourself, and then we're gonna dive into the meat of today's discussion.
Yeah, great. My name is Grainne Bourke. I'm a consultant in hand and plastic surgery working in the Leeds Teaching Hospital Trust. I work in congenital hand surgery, nerve injury and microsurgery, and I'm actually also the president of the British Society for Surgery of the Hand this year, which is great for children with congenital hand anomalies. Puts us to the fore.
Yeah. Fantastic.
Thank
We're
you.
very grateful to have you here today for today's session. So
Yeah.
we've compiled a number of questions around this important and quite far-reaching topic.
Yes.
I might actually first start with Giampiero, because as an orthopedic surgeon, I think it's going to be really interesting to kind of compare and contrast the roles and the approaches to both bony reconstruction as well as soft tissue reconstruction approaches before we talk about the kind of the interface to the patient and their carers as well and their families. So Giampiero, maybe if I could start with you. Can you just outline for us in general the role of bony chest reconstruction as it relates to patients with Poland syndrome?
So since we are on record, let's be honest, and I can tell you that I'm not an expert. As I said, I'm a general pediatric surgeon with an interest in thoracic surgery. Usually is a non-cardiac intrathoracic surgery with a bit of chest wall reconstructions for some children born with congenital chest wall deformities. Usually we are talking about pigeon chest or pectus carinatum or pectus excavatum when they have a dent into the sternum, which, by the way, there are two conditions that often are seen in children born with Poland syndrome. Regarding the specific other chest wall deformities that Poland syndrome children might have is when they are missing one or more than one rib. I don't have a direct experience in fixing these problems with this specific group, but I have some experience in reconstructing the chest in children who unfortunately developed cancer involving the soft tissue or the bony tissue of the chest wall. And in those children, after we remove 2 or 3, sometimes more ribs, then we simply reconstruct the chest with Gore-Tex patches, and is what basically we would do in children with Poland syndrome missing one or more than one segment of ribs. I must admit that since we started our focused clinic and service at the Birmingham Children's Hospital, we have not seen one single patient with missing ribs. And my understanding from the literature is that it's not that common. So that's basically my answer. I haven't done it yet, but if I will have to do it, it will be just a simple reinforcement of the gap using this Gore-Tex special made sheet, and which are quite resistant at the same time pliable, and it will offer a nice support for my plastic colleagues, plastic surgeon, to reconstruct the actual soft tissues.
Thank you, Giampiero, and taking on board your comments about your level of exposure and specialism in this area. Nonetheless, I've heard the term splinting used as an alternative to surgery. Are you able to define what that actually means and maybe what are the criteria?
I'm not familiar with this term. For what I can think of for splinting, that some surgeons have been using actual metal ribs to bridge the gap where the rib is missing. As a pediatric surgeon, I don't have a direct experience with that, but my previous colleague who had used it, they were very disappointing, because we are talking about young children, and of course the timing of surgery is critical, but if you apply one of these metal ribs to bridge the gap, there is a high risk of the surrounding tissue will overgrow, and the actual metal splint or metal rib will erode through the soft tissue. So overall, we are not happy with this kind of possibility. Yeah.
Andrea, can I bring you in? And of course, Grainne, if you've got some comments on this particular topic before we start talking about more soft tissue methods, I'd welcome that. But Andrea, did you want to come in on this?
Yes, thank you. I think there is a difference in an internal splinting and external splinting, and obviously there are descriptions of titanium implants to reconstruct ribs. especially by some American groups. Giampiero, how do you perceive the role of external splinting, for teenage, especially for teenage boys?
As I said, I have a very good experience with a simple Gorotic sheet, and I think it's more easy for the surgeon, more acceptable for the actual patient. It can be done at the same time of the soft tissue reconstruction. There are much less risks of erosions through the tissues, infection, and so on.
Grainne, I'd love to bring you in on this as well, if possible.
Yeah, thank you, Peter. Listen, just to say, in my experience, and I think generally I'm speaking on behalf of the Leeds team, so we have like a long experience in Poland syndrome and congenital hand, like Birmingham as well. I haven't really seen anybody need rib reconstruction that's come through our clinic. I think some patients do have a defect or their ribs taper out. Sometimes they've got kind of fascial area instead of ribs. So it's kind of like a tapering, in particular anteriorly underneath where the breast might be. But nobody has really required any kind of reconstruction for that, because when they have the soft tissue reconstruction, that kind of protects it very nicely with the LD and disguises it. It's not perfect. So I don't think that you need a reconstruction necessarily, because the integrity of the chest wall is still there. I'm obviously not an expert on the bony construct, so I'd have to default on that. But just to say, like, the experience generally is, I don't know that it's necessarily needed. And I agree entirely with the risk about the growth and everything else. I think we just have to be careful. Yeah. Thank you. But I don't know. I haven't got experience of it, so I'm just saying, I don't know.
That's really helpful. I think it once again underlines the kind of broadly there's such a different exposure into clinical groups to this condition, and hopefully what we'll be able to do is provide some sort of consensus or sharing of information. Just before we talk about soft tissue reconstruction, Giampiero, you mentioned, and the other panelists have alluded to the kind of the factor of age. So in a situation where bony reconstruction is being considered, how does age play into that in terms of the age at which of the patient at which that should be conducted?
I think as a group, we agreed that reconstruction should be considered in the teenager years. We want the child, the young person, on board in the decision-making. We want the young person with Poland syndrome actually to understand the implication of this kind of surgery. We want a young person who has gone already through the changes that you would see and expect with puberty, and towards the end of that period when you know that the entire body is stabilizing, that they are not growing anymore. So the opposite side of the body is matured and formed, and so any reconstruction, prosthetic or cosmetic reconstruction, will be matching that side. So I would say that, teenager years, late teenager years.
Some really helpful considerations there. Andrea, can I come back to you potentially for a comment on what we just discussed, but then also to start to approach the topic of soft tissue reconstruction, which I know you've carried out a lot of research into different methods.
Yes, just to come back to the chest wall reconstruction. Since we've started the Poland's clinic a couple of years ago, obviously we've seen that, and I can only mirror what Grainne and Giampiero obviously said, that we've not seen a child with a major rib failure. But the literature does describe very severe forms of Poland syndrome, where not only 2 or 3 ribs are missing, but more. And there have been anecdotal reports of custom designed titanium implants, etc. We certainly in Birmingham don't have experience with that, or at least I've not seen us using that. But I understand, Giampiero, that you've said that in the past for other indications in chest wall reconstruction with permanent implants, the experience was not as good as potentially expected. So it's really important that we don't throw Poland's and Poland's into one pot, because there are various graduations of Poland's syndrome, and we are just learning, at least in Birmingham, we are now learning that we have to be very clear on how to classify Poland's syndrome, how to graduate Poland's syndrome, including all the associated problems potentially around the shoulder, around the spine, and other associated issues.
Thank you, Andrea. And again, I think something that we maybe, if we have time, we'll come back to towards the end is the role of standardized classification, particularly when we talk about how registries have the potential to help drive forwards improvements in care delivery. I'm aware that you've, as if you didn't have enough to do, you've also done quite a bit of research into different approaches to soft tissue reconstruction. I'd be very grateful if you could maybe give us a view of the landscape, if you will, and then maybe we can talk as a panel, if you can maybe talk about some of the considerations which might move you to choose one or other of those approaches.
Well, it's a very, very interesting topic, and it's a very hot, I wouldn't say hotly, but for the parents is a very important topic, because depending on which unit they visit, they may get a different view on things. And apart from what Giampiero has already said that at the Birmingham Poland's MDT, we usually advise the families, if they see them young, to wait until the child is older. The reason for that is because we feel that the cosmetic aspect of the backside might be as important to a young person as the front side, and that it's really important to make that decision. But I appreciate that that might be discussed. Coming back to newer techniques potentially for soft tissue reconstruction, obviously, previously since the 1980s, I think the first description was around the early 1980s of using a lat dorsi to reconstruct the front side, and that's been for a long time the workhorse in reconstruction of the anterior chest wall for the soft tissue reconstruction. But over the past couple of years, newer methods with expanders and lipomodeling, expanders, implant, and potentially omentum flaps have come and have been described not only on a small scale, but on a larger scale. And the results obviously seemed quite favorable. Especially the Americans start to put an expander in the early teenage years and start to expand the tissue and then do potentially gradual lipofilling. That seems to be also an approach in the UK in some centers. If there is no fat for the older children or young people, they may then choose, instead of lipomodeling, they may choose an implant, custom made for the boys or the girls, depending on what they need, and then endoscopically harvested omentum flap. So in Birmingham, what we do is we counsel the patients. We've not gone the route of early expanders at the age of 11, 12, 13 and lipomodeling. We wait until they are 15, 16 and then discuss reconstruction with the families. Potentially then asking the adult sector, because we are a standalone hospital, we then have to rely on adult breast surgeons to support us with that. So I would be really interested what Grainne's take is on those, on the evolvement of potentially newer described techniques. Yeah.
Just before I'd love to pass across, just for those of us like myself who aren't as clinically versed as you are, you mentioned an omentum flap. What's the purpose behind that when combining it with a silicone implant?
So the problem with if you just expand very thin tissue and you only have skin is that when you put an implant then in, you either take muscle from the back and then use the muscle from the back to cover the implant to give it shape or form. But if you don't want to take the muscle from the back for various reasons, this could be cosmetic, this could be other reasons, then you have to cover the implant in order to make the edges look softer so that it's not immediately obvious as an implant, but to have a very soft appearance of the breast, especially in women. Then you can use thin, soft layers, and the omentum is, Giampiero is probably much better equipped to explain what omentum is part of the tummy, which it's tummy fat, isn't it? Which covers the tummy, and that can be harvested and used on top.
Yes, the omentum is a blanket of fat with many blood vessels that hangs from the stomach down inside the tummy. And the paper that you are referring to is the one from Chile, I think Romanini and al. And they use the keyhole laparoscopic approach to harvest a flap of this omentum and to bring it up into the chest, often to cover synthetic silicone implant. So to give an extra layer of softness, to give an extra layer of protection between that tissue and the surrounding tissue, so to prevent inflammation, infection, and so on. And as Andrea said, to give that nice texture. And of course, the blood supply covering the blood supply of the omentum, covering that synthetic material will prevent infections.
Thank you both. And Grainne, I'm sorry, my natural curiosity got away with me. Andrea posed, I think, a very clear follow-on question in your direction about how you then start to consider when one of these approaches might be more appropriate than another. It'd be really great for you to kind of move the conversation in that direction, if you will.
Well, I think, to be honest, I would first like to hear from Grainne because the Leeds group has a significant experience and potentially or potentially not might have a different approach to things. So it would be really interesting to hear from Leeds.
Yes, definitely. Grainne, please.
Okay, thanks, Andrea. Yeah, so I'll just give a background for Leeds because we have got, you know, a long experience with Poland. And I suppose that we're talking really about the chest wall, but, you know, some children will come with just a hand anomaly and then we'll pick up the chest wall deformity in clinic, obviously. And some people come with the chest wall deformity, and then when we'll examine them, we'll see that there's a hand anomaly. You know, it might be just the hand was smaller, as we know in this group, because everybody's specialized in Poland. But that's sometimes how patients get referred into clinic. But in our clinic, we do have multiple, you know, it is multidisciplinary, and there's probably a couple of people that are very important with the Poland group, and one is the psychologist. And that's we have that for all our patients and children, and I think that's probably something that's translated across the country now, which is really good, because we know that the psychological aspects of any condition are probably as important as any surgery that we're going to do, and not just for the child, but also for the family, because they're the parents are the first ones that kind of like understand the problem or the difference. Rather, and they, you know, want to explore that and their feelings before the child actually even realizes there's a difference. Am I speaking loudly enough? Sorry. Yeah. So that's probably the most important thing. I agree with Andrea. There's kind of a spectrum. I think probably we have to think about the spectrum of anomaly when thinking about the reconstruction. But there's two things that I kind of think about it myself, really. One is there's a problem with the breast, which we've kind of talking about with the lipofilling and the implants and various things and the soft tissue component. And then there's the problem with the kind of like general breast base. And part of that is the pectoralis major muscle. And so we know that from children, some of them will be missing like just the sternal component, which is where the muscle attaches to your breastbone and goes out onto your arm. And some children will be missing the clavicular part, which is where it's onto your collarbone as well. So basically they're two quite different pictures when we see them in clinic, even though they're both Poland. So I totally agree that there's such a spectrum and everybody needs something a little bit bespoke. On top of the fact that there's the muscle defect, there's also a deficiency in the soft tissues between the muscle and the skin. So the fat is kind of thinner, and that's kind of important for girls, but really for boys as well, because we know that teenage boys are very self-conscious about appearance. Even, you know, as much as girls, and we just can't forget it, like, because everybody focuses on breast reconstruction, but the boys are also missing part of their breast space as well. So I think that's probably maybe for them where the fat lipofilling would be more, you know, more suitable. The other difficulty with it is, I also agree that a lot of these children are super thin teenagers. So when they come to that phase, having a donor site for lipofilling can be quite challenging. And so sometimes, you know, we actually go for expander, and then maybe, you know, once they've kind of finished growing, this is for girls, go on to an implant. Boys, I would very rarely recommend an expander or implant. Because the difficulty is disguising it, which I think we talked about there, and it can be quite complicated. With regard to the latissimus dorsi, and I'll stop in a minute because I know it's just, you know, this is a discussion, but it's a kind of an anatomical reconstruction of the pectoralis major. So historically, when people started doing the latissimus dorsi reconstruction, they did it for chest wall cover, but they didn't take down the tendon of the lat dorsi from where it attaches onto your arm. So essentially the functions of the latissimus dorsi, which is the muscle at the back that we move to the front, it rotates your arm in and it brings your arm into your side, and it helps you for climbing and things like that. And your pectoralis major does something quite similar. It's also an adductor, so arm into your side and rotate around, but they're attached slightly differently onto the inside of your humerus. And the reason that's really important is because what we want in the Poland's reconstruction is we need to reconstruct the anterior axillary fold line, which is your armpit. So what people don't like is you look in and you put your arm out and you can see straight into your armpit. It doesn't matter when you're 3, but when you're like 15 and you've got a hairy armpit, people don't want to see it, or they're embarrassed about that element of it, I feel. So it's more than just the breast reconstruction. It's also if you're wearing a vest top, you kind of need that element of kind of like basic chest wall reconstruction. So I agree, it's a spectrum. And I think new techniques are great. The lipofilling, I've experience with the Menta, but not in the situation for covering an implant, I have to say. Again, I just wonder about, like, you know, how far it reaches and the amount of tissue that you'd get in a thin teenager to cover an implant, and if it's necessary. So those are the kind of things I think. I also feel like I know the latissimus dorsi is like, it's something that we've used historically, but it's also part of the person. So it's a living tissue, it grows. We just basically change it from where it was latissimus dorsi to kind of like a new pec major. And so it's growing with the child. And I know we're going to get onto age later, because we do tend to offer the families early surgery as well if they come early. And that's with the MDT and with the psychologist as well. But I think that's very important, that it's not a foreign material, it's actually part of the person that's going to live and grow with them. And I'm going to stop now because I want everybody else to, I could talk forever. So, thank you.
That's absolutely brilliant, and I wouldn't stop you. But I think age. Let's come back to that, because as you've highlighted, it's definitely a factor. Just a reflection is, our last webinar, we were lucky enough to have some of your colleagues professionally from Italy, and it was striking the different role in terms of psychologists in that multidisciplinary setting, whereas in the UK they are in many cases, if not universally, quite well embedded, as you described. So I think it's always important to, again, we're trying to share what has worked more globally, trying to understand how different disciplines are important in that picture. I'd love to throw it back to Andrea and to Giampiero, just keying off some of the comments that Grainne made, and then maybe we move on to talk about specifically some of those age considerations. Any immediate responses to the pretty broad review that Grainne has given us?
No, I completely agree. As I said, I'm not an expert of soft tissue reconstruction, so I respect what Grainne and Andrea experienced with me.
So I think it's what's really becoming very clear, that Poland is a spectrum, and that the patient is an individual patient, and that we have an armamentarium of different things. And I think the reason for important webinars like that is to potentially be able that we within the nation of the UK, we have a bit more, I wouldn't say guidance, but that we work with each other and not against each other, because otherwise parents will go from Birmingham to Leeds, from Leeds to Birmingham, and it'll become, and it's not, and it'll be difficult for the families. So if we come to a point that where we can say, yeah, well, every patient is individual, this is the tools that we have at hand. I think the reason, just to clarify a little bit, why in Birmingham we take maybe a slightly more laid back approach to early reconstruction is because, especially in boys, we feel that or we see that the dorsal silhouette, we call it, you know, the way you look from the dorsum, the triangle, the male triangle, might be as important as the front bit, and that because of that it feels to us very important that it is a joint decision with the patient that needs to be taken, how they approach that. And probably, Peter, from your adult male patients, especially the ones, I mean, you have the Paralympians, you have your VIP comedians. It's also important to hear how they view it, and it would have been maybe good to have them maybe on the next panel as well, because they've made potentially different choices. I'm not sure which choice they've made, though. So yeah, that's just a little bit of a comment towards the cosmetic aspect, not the functional, obviously, that Grainne mentioned, but the cosmetic aspect of the male silhouette. I've looked a little bit, because obviously there's always a little bit of what happens if you take the lat dorsi in a very young child, in a child who might have Klippel file or who might have a Sprengel shoulder. So not the type 1 Poland's where it's just the pec major missing, but a child who might have associated abnormalities. We know that the lat dorsi can be missing. It can be missing unilateral, bilaterally. And to be honest, I have found nothing. So I couldn't find a robust study on the various types of Poland reconstruction with lat dorsi and the various types of Polands. They were all bunched together. They were classified with different, no classification at all. They were measured with a DASH score, which is an entirely inappropriate score to measure this type of thing. So it's very, very difficult to find robust data on donor side morbidity for muscle transfers in children who might have associated comorbidities around the shoulder, like Klippel file or Sprengel shoulder, and whether that has a destabilizing potential on an already weakened spine or not.
Grainne.
Yeah, I think that's a really great point, Andrea. I haven't seen a patient with Poland's and Klippel file or Sprengel shoulder. Generally for the Sprengel shoulders, you know, it's just the relocation of the scapula and the omental vertebral bar to divide and try and, you know, lower the scapula down. So I don't have experience with that. I don't know about the others in Leeds, but I don't recall seeing anybody. I think that's the type of case we would have together quite intensely. So I agree. I haven't got any experience with moving the lat dorsi in those patients. Just the omental vertebral bar. So yeah, interesting.
Grainne, something that you said very clearly is the lat dorsi. It's a living muscle, or it's living rather, and I'm aware, and it's kind of come through the Q&A, that there's certainly been experiences within the Poland syndrome community that they experience atrophy in the lat dorsi rather than it growing with them post-transfer. And again, I'm not expecting a systematic review, but be keen to hear how you and maybe the other panelists, what your view is on that, if you've experienced any of that kind of atrophy in patients who have received that procedure.
I have to say I haven't seen anybody with atrophy, but if it's somebody who said put that in, please let us know. Generally, the idea with the muscle is exactly, it's living. We keep it with nerve supply if it's from the same side. Essentially, what that means is we keep the nerve and the blood supply to the muscle, which is basically in your armpit. That's where it comes. So it's kind of like we change it from the back to the front, and then we reattach it. So it's stretched out just like the muscle, and then because it's under tension, and we change the tendon location, then it features like a new pectoralis major. I haven't seen atrophy. Sometimes early on, straight after the transfer, maybe the nerve connection wouldn't be as strong. but that's unusual, in particular in a small child. Sometimes if children are missing the lat dorsi on the same side as well, we have transferred the lat dorsi from the other side, which is basically taking it off and transplanting it, and we put it into the intercostal nerves, which are nerves that are in between your rib and help with breathing. But we know that we can take them from looking at other conditions. We can take a few of those nerves. We've got 12 on each side, so we can kind of take a few. And that they also seem to work quite nicely, in particular in small children, because we know their nerve regeneration is really much better than even teenagers. So that's evidence-based. Kind of once you go into double figures, nerve regeneration, plasticity kind of tailors off, not dramatically, but over time it gets lesser. So we have evidence. I mean, some of that is published, but I feel so if there's atrophy, I'd be interested to see those cases for sure. Yeah, and we have somebody who's looked at our series and put it forward, but it's a difficult thing to kind of measure, I suppose, as well, because it's kind of like a volume measurement. So that's the difficulty as well.
I just wanted to say the same thing. Sorry, Peter. It is very difficult because one would have to measure the volume before and a couple of years after. When we transfer muscles, because they have now a different work to do, they might change, adapting to the new type of work. And obviously we are assuming that the work of a lat dorsi and a pec major might be the same, but actually it might be that the pec major has less work to do, and then the lat dorsi, because of less work, may adapt, which could look like an atrophy, but actually it's just an adaptation to the new situation.
Interesting, Grainne.
Yeah, sorry, I was just thinking about that. Yeah, I agree, Andrea, like it could be a different adaptation. And the other thing to think about is, I guess, as you grow, your kind of physique changes. So when you're really small, you have a little bit more subcutaneous fat. And then as teenagers grow and get taller, or children, or even adults, if you're thin, then the appearance and the breast changes would probably be more apparent. So it could be that the difference is more noticeable as there's changes in kind of puberty and breast development, which would happen anyway. Do you know what I mean? So it's kind of a difficult one to know, is it atrophy or is it just that the difference is more apparent because there's those changes of growth. Yeah.
Andrea.
Grainne, can I ask, obviously that is a lot to do with boys. How do you deal, because obviously girls will need most likely a secondary procedure later on with the breast reconstruction. So how do you counsel the families with regards to a lat dorsi in girls early, knowing that they will need a second procedure? Is there a difference in discussing with them?
Yeah, to be honest, no, that's a great question. Like they all go through the psychology, really, the psychologist who has like videos and a great experience with dealing with these patients. So they have before and after videos to look at. And it is a kind of a lifelong, like a lifetime discussion, if you know what I mean. I actually don't sit in on that discussion, so I don't know everything that's discussed, but I know like from the idea, they also discuss the changes or the timing for girls, and we discuss it in clinic as well. So when the family come early, that whole kind of life sequence of what might happen now and again is already discussed. But generally what happens is for girls, we do the lat dorsi, like it's kind of standard. And then for girls, what happens is I normally say to patients that when they start having breast development and they get a bit self-conscious about it, or there's something that they're bothered about, they represent to clinic, and then we kind of have a chat about, like, how are you managing it? Are you managing with something externally? And they go through discussion with psychology, and at some stage then they may transition over to have an expander put in. What that is, I don't know, it's kind of a balloon that we put under the skin that we can inflate with some salt water over time, and it gradually increases the volume. So basically we can do that on a regular basis, and it tries to get some symmetry of volume for the child. And that can be very helpful for young girls who are between like 13 to 17, I'd say, because, you know, sometimes they come and it just really depends on the contralateral, on the other breast, what's happened. Because some girls can have quite significant breasts on the other side, and then they're really self-conscious. So we do the expander, and then it's the discussion about the long-term outcome for breast reconstruction. And that's a different discussion, and we're really lucky. So we have like Leeds is co-located with the adult hospital, and I actually do adult surgery as well. So I have young adults that I see myself, and also of course we have breast colleagues, because you know we know that there's a lot of people subspecializing in breast in particular. We kind of share.
Can you guys still hear Grainne? I think I've lost her. Peter, you are muted, but I can see you're talking. At least you're moving.
I was just saying we'll give her a couple of seconds to come back, and she's frozen for me as well. Just while we're waiting, maybe, and this clearly this topic is as fascinating and relevant to me as it is to our audience, because we've had another question come in, and again, I think what we're hearing underlines the need for more research into surgical outcomes. You said, Andrea, there's not a lot out there, paraphrasing. But another question's come in around whether or not systematically or anecdotally there's any short or long-term functionality changes associated with that lat dorsi procedure. Are there any kind of common themes that you're aware of?
So that's what I've been referring to as well. I found, well, looking through the literature, I found 2 or 3 descriptions. The problem is, we know that if you take a lat dorsi in an adult who's not necessarily a wheelchair user or a competitive swimmer, it doesn't have a massive impact apart from the cosmetic aspect from the back, but that's adults. There's no published evidence that I could really find of a robust nature what the impact is on a child who potentially already has a spinal problem or other issues. If you take the lat dorsi, whether that leads to any problems. There are a couple of descriptions, but because they are not age-based, it doesn't say that lat dorsi was harvested in a 3-year-old versus a 13-year-old. There is a difference in growth. A 13-14-year-old is almost fully grown, whereas a 2 or 3-year-old, it goes through a full phase of growth. And there's nothing in the literature suggesting. So as much as I wish I would be able to tell you that harvesting the lat dorsi in a 2-year-old doesn't matter, we can't. It is an important muscle, but we don't know.
Andrea, you might remember that we saw a child, a young child in our MDT clinic who had muscle operation when she was a toddler, 2 or 3 years of age. And I'm not a plastic surgeon, but I wasn't particularly impressed by the actual outcome. Now that she's about 7, 8 years old, now she's got an ongoing anterior chest wall defect, an unpleasant pocketed scar on the side of her chest. And as you said, the back doesn't look great now. It's asymmetrical.
That's really interesting, and Grainne, great to have you back. I think what you can tell it's a lot of questions are being prompted from the discussion that's being had. There was a question we were just fielding about whether or not there were any sort of recognized long or short-term functionality changes from the lat dorsi. We've actually had another question that's come in, and from the way it's phrased, I'm almost certain from someone with a much stronger clinical background than mine, but just a point of clarification that you may have covered this earlier when you were talking about the humerus attachment points, but the question was, when you carry out a transposition of the lat dorsi, do you also move the origin of the tendon on the humerus? So is it reattached in a different position anteriorly?
Yes.
Okay. I thought so.
Yeah, no, exactly. That's a really important point. So we we detach the muscle and then reattach that onto the sternum, which is like the breastbone, and that gives you, and then you need the fan appearance. And the difference between pectoralis major and a lot of the other muscles is that there's 2 elements of it. the kind of sternal component and the clavicle component. I know my hands don't look like percnasia, but anyway, if you can bear with me. But the bottom component, which is the sternal component, the insertion onto the humerus actually spirals underneath the top one and gives you that kind of armpit appearance. You know, you see those guys with those big pecs. That's actually how the tendon grows. It's got two type of elements. So in those patients that only missing the sternal component, they can get a really nice reconstruction because the lat dorsi only has a single tendinous component. Whereas those patients that are missing both parts of the pectoralis major is more difficult, because sometimes it's quite difficult to fill the upper component near to the collarbone. So yes, so that's a really crucial bit. And it's very straightforward to do it. We do it at the time, and it makes a big difference to the outcome, I would say. Yeah.
Thank you. We've got just under 10 minutes left, and there's a sign of a good topic. People are really, as I say, a lot of interest there. I wanted, if I may, just take a bit of a broader view across all of the interventions that we've discussed so far. There's obviously interest around, or concern potentially around, potential complications from surgery. So I'd really, again, considering any of the techniques, the approaches that we've discussed today, or maybe all of them in comparison, what are the panel's views about likely potential complications from surgery, I guess, including the hopefully never event of morbidity from surgery. But maybe it'd be good to get some perspectives on, when weighing up the need for surgery, what may sort of tip the balance in away from it.
So surgery is there's not a single type of surgery that does go along that doesn't have any risks. Nothing. The moment we take a knife to a patient, even if it's just for a scratch, it can lead to complications, including infection, including bleeding, including an unsightly scar, and basically a worsening of the patient's perception or the carer's perception of the situation as it was before. I think that is a basic rule for all surgeons. And if any surgeon tells you anything different, I think they're not being realistic. All of the interventions that we have been describing have inherent risks, and any honest surgeon will describe those inherent risks to the families. That's
a reassuringly balanced perspective on that. I wouldn't argue with any of that, and I think maybe then that clearly then leads on to, as you've already moved to, is how as clinicians weighing up all of these options, do you go about explaining the treatment options to patients, and as a result, partly as a result, obtaining consent for the procedure? And again, conscious that there's a huge range of options, inherently patient dependent, but what are some of the approaches that you have found most relevant when being presented with patients who've got Poland syndrome? Maybe come back to Grainne and then Giampiero, and then back to Andrea on that one.
Yeah, thanks. I was going to say, not to have Andrea always on the hotspot first. Yeah, I think that's a great question. I think the thing that is really important, I think, is, one, we are very fortunate to have psychology. And what happens is we can go through the risks and complications. This is for surgery overall, but in particular for like making a decision for someone else, which is a parental view, and for a young child for assent, because they can't consent themselves until they're like and even for those children or those teenagers who are 16 to 20, they still probably need psychological support in making the decision, because what we've got to decide is, we can give them the information, but then it is like, what of that information, how much of it did they understand and take in and understand for the future? And that's probably one of the most important aspects of it. So our role as clinicians is really to inform people about what's out there, what's available, what we can do, what other people can do. And then we aren't really allowed anymore kind of like tell people this is what you should do. Nowadays, it's consent, and the patient has to make that decision. But that is a very difficult decision in those situations, and that's where the psychologist fits in. And if for any reason anybody, like a parent, group parents of a small child, or a teenager or somebody is not sure, then the advice is don't have the surgery. You know, if you're not sure the complications or what you've heard, you're a little bit worried about something, then you just park it and come back and look at it again another day. And I think that's the advice that I would say, and that comes from, I've learned from the psychologist, is like, you know, this is all elective surgery. It's about life, quality of life, making you happier, you know, allowing you to do more things, be confident. And so it's really important that, you know, the decision is made, you know, in the right kind of like situation with the right support.
Thank you. That all makes a lot of sense. And Giampiero and Andrea, I'm sure your approach isn't by any means a million miles away at Birmingham, but is there anything you'd like to add about how you weigh up those options and present them in a way with your colleagues to patients and their families?
Yeah, no, Grainne put it very nicely. When we are dealing with medical conditions, which the burden between, you know, problems and anatomical variation is very blurred, is always a difficult conversation with a young person. And that's why we want to make sure that they are mature enough to understand the implication of the surgery. They have to have a complete informed consent. They have to be aware of the possible risk of complication. At the same time, we want to support them because mental health issues are quite an important problem. And we live in a different age, and the body image is quite important, and it has got a huge impact on mental health in this young generation. So we would like to help them, but at the same time, we need to let them know about the risk of complication of any cosmetic or prosthetic surgery, including the failure to meet the expectation.
Thank you. And we've got a couple of minutes left, so obviously at the point of wrapping up. But I think maybe if I can, Grainne, just quickly come back to you, and then maybe just reflect and link this maybe through to what we can do going forwards as a charity and as a community.
Yeah, I was just going to say, like, I think one of the most important things is getting the information and kind of feeling like for families or for a child, for an adult, teenager, whoever it is coming forward, I think it's about getting information and feeling part, which is where like the Poland Syndrome Support Network is brilliant, because you want to have people who have the same experience of you. And then some people will find that surgery is the right thing for them, and some people don't want surgery. And there'll be people who are happy with both aspects. And it won't be related to the Poland syndrome. It will be related to everything else that surrounds them, which I think is probably, you know, that's the same for all of us. So I feel like, you know, working together, you know, I agree with Andrea, working together across the country, because we're lucky we got the NHS, and working together with the support group, with you, Peter, is also really important, because, you know, what we want is kind of holistically to support everybody, so that everybody has the right outcome for them, whether it's surgery or not.
Thank you. And I guess just reflecting, you know, coming into this discussion, I suppose I had a view that there was almost a kind of a binary decision between early versus late intervention. Clearly, there's a lot of factors in an individual, but also at a clinical practice level that would go into that. And you've talked, you know, everyone's talked very eloquently about the factors of gender, and, you know, the aesthetics certainly aren't by any means confined to girls versus boys. I think what I'm taking away from this is that while surgery often is thought of a one-time event or a point-in-time intervention, actually, as has been mentioned, it's part of a continuum of long-term care, both physical and psychological, and options available at certain ages will change, and also the need for them will also evolve with the individual patient. And it's important that we given that it isn't a one-size-fits-all solution by any means, that we continue to make the factors that go into deciding this, and what criteria that may become more and more relevant, as widely known in the most rigorous manner possible. We have 30 seconds left, so I'm going to ask the big question now. As I mentioned at the beginning, we are maintaining a Poland syndrome registry. We're very keen to drive meaningful insights and support to the community. And I guess, is there any closing comments about how, at a high level, we might use that registry to drive improvements of care, standardized classification, for example? That would be very welcome just before we wrap up. I don't know, Andrea, maybe you or Giampiero, maybe you had a thought on that just to close us out today.
Well, we've asked the PIP charity to maybe we've sent a couple classifications that are basically out there. The Romanini classification 2016-2018 for the chest wall, obviously. Then for the hand, we have Catena and Perez Lopez, the newest one. And the question is whether we can agree maybe between those centers, let's say Leeds, Birmingham, to use, if PIP sends us maybe a chart, so almost like an assessment, a crib sheet, and that we both use the same type of assessment instruments. So we certainly have fallen, we were not very good with that. We've seen the patients, we've kind of been very descriptive, but we've now decided that we want to be more better with that and put them into proper classifications, and we've asked PIP to help us, and maybe PIP can share the same thing with Grainne, and it would be great if we can, Leeds and Birmingham uses the same crib sheet, because then comparison, at least we know how many type 1, type 2, type 3s, etc. we see. And Grainne, just last thing, we see exactly the same. Most of our Poland's patients actually come because of chest, and then we see the hand and see that the hand is smaller and it was never picked up before.
That's a very, very concrete and practical step to leave us on. I couldn't ask for any more. And I'd just like to finish by thanking our three panelists, Giampiero Soccorso, Grainne Bourke, and Andrea Jester. Thank you so much for your time. Thank you, everyone who posted questions. Once again, this will be available to watch again for those of you who got the link. And look forward to our next of these sessions, by which time hopefully we'll be able to report back on having moved forwards more of a systematic approach to understanding the data to the benefit of patients, clinicians, and their families. Thank you all for your time today. It's been a real pleasure to learn from you, and look forward to seeing you again as soon as possible. All the best. Thank you.
Thank you so much, Peter. Thanks, everybody. It was really great, really interesting. Yeah.
Thanks, everyone. Bye-bye.